In this video, we discuss bacterial meningitis. It is also called pyogenic meningitis. It is a life-threatening CNS infectious disease affecting the meninges. The causes are age-dependent. Main three infective organisms are Streptococcus pneumoniae, Neisseria meningitidis, and Haemophilus influenzae. Few predisposing factors are known. Elderly patients, 65 years. Splenectomy and hypersplenism state, alcoholism, HIV/AIDS, diabetes mellitus, cancer, anatomical defect are related to recurrent meningitis, and organ transplant recipients. The infections reach to the brain via hematogenous dissemination, the adjacent focus of infection, such as sinusitis or otomastoiditis. An infected foreign body, like a shunting catheter, congenital, or acquired structural defects in the skull. Clinical manifestations include fever, headache, stiff neck, photophobia, lethargy, and confusion. The diagnosis is usually confirmed by lumbar puncture and CSF analysis. If LP is contraindicated in suspicion of brain shift, basal cistern effacement, and cerebellar tonsillar herniation, CT is indicated. Clinical indications are focal neurological signs, papilledema, and continuous or uncontrolled seizures. The Glasgow Coma score is less than 12. In uncomplicated bacterial meningitis, CT is often normal. However, in non-contrast CT brain, sulcal effacement and slight hyperattenuation, subtle distension of the subarachnoid spaces, and prominent basal cisterns can be seen. In contrast-enhanced CT, leptomeningeal contrast enhancement can be seen, which follows the surface of the brain and extends into the sulci and basal cisterns. But changes are better detected by contrast-enhanced MRI. FLAIR images are better to distinguish from contrast enhancement in normal blood vessels vs abnormal leptomeningeal enhancement, less sensitive to vascular enhancement. In FLAIR images, increased signal intensity in the subarachnoid spaces, most often over the frontal convexities, and in the sylvian fissures. But FLAIR hyperintensity is nonspecific. Other differential diagnoses are subarachnoid hemorrhage, malignant meningitis, or cases treated with large doses of supplemental oxygen. DWI images show multiple foci of high signal intensity in the subarachnoid spaces, which are secondary to vasculopathy of arteries surrounded by inflammatory exudate. These are typically nodular and are associated with increased signal intensity on the FLAIR sequences. This is associated with a poor prognosis. These focal lesions are classified into four patterns: large vessel territory infarcts, perforated territory infarcts, multiple bilateral lesions in the cortex and subcortical white matter, and multiple bilateral lesions restricted to the cerebral cortex. Complications of bacterial meningitis include hydrocephalus, abscess, cerebritis, a cranial nerve lesion, thrombosis, infarctions, ventriculitis, vasculopathy, or extraaxial collection like empyema and hygroma. Hydrocephalus is most often of the communicating type. Management of bacterial meningitis includes empirical antimicrobial therapy. Differential diagnoses are fungal meningitis, usually exhibit a thicker, lumpy or nodular enhancement, and viral meningitis.
If you like the video, you can like it, comment it, and share it with your friends. If you are not subscribed yet, please subscribe and click the bell button.